The broadcast is now starting. All attendees are in listen-only mode.
Well, hello everybody. It's John Yu here. Oh, sorry, I didn't put my name on this title slide. So this is the first in our series of iCAN-ACP team webinars. So it's really great to see people connecting from all across the country. Hopefully people will find this a useful format for our team to stay a bit connected since we are so geographically spread out. Just one housekeeping item, actually two housekeeping items before I start. One is that this webinar will be recorded and we're going to find a way to post it on a website that we're developing. So you can stay tuned for more information about that. The second thing is that there is a function that will allow you to ask questions in your control panel. So you're welcome to submit questions at any time throughout my presentation. And I will leave 10 or 15 minutes towards the end so I can try to field as many questions as possible before we sign off at the end of the hour. So as some of you may know, I'm the project leader for the iCAN-ACP project that's funded by Canadian Frailty Network. It is a 3-year transformative grant. The other role that I play in this iCAN-ACP project is that I'm the lead for the work that is going to take place or that has already been taking place in the hospital setting. And so what I thought I would share with all of you today is some background and then our experience with implementing the serious illness care program in the hospital setting and share with you some lessons learned. So in terms of the format for the talk, I'll give you just some background about the current state of affairs as it relates to communication about goals of care with patients in hospital who have serious illness. I'll give you an overview of the serious illness care program, which some of you may have heard a bit about. And then I'll talk about our experience adapting and implementing this program on a hospital ward where I work at the Hamilton General Hospital on the medicine unit. I'll reflect on some lessons learned and then we'll have time for questions. So first, for just some general background, I really like this slide because it shows the different ways in which we die. And I think the interesting thing to point out with this slide is that compared to 1 or 2 centuries ago, it is quite uncommon now for people to die a sudden death or to die fairly rapidly with a terminal illness. The majority of deaths, probably around 2/3 of deaths currently, follow the more prolonged trajectories that you can see in the bottom 2 quadrants of this slide. And the implications of that, I think, are that because of the prolonged dying process for many of us, there are many more decisions about care that need to be made, and that these decisions are quite likely to be value sensitive. In other words, they depend greatly on what an individual patient might feel is most important to them at that phase in their life. Prior research that asked seriously ill patients in hospital what was most important to them in their care at the end of life found the following items: feelings of peace, availability of their doctor, emotional support, feeling heard and listened to by their care team or their doctor, and receiving consistent information. So taken together, and these were things that the participants in this study identified as extremely important, but things that they were not currently satisfied with in terms of their care in hospital. And so these items are identified as high priorities. And if you can sum up these bullet points by saying patients really are looking for really good support with communication and decision making when they are seriously ill. In the past few years, in my work with the CARE-NET research group, we've had the opportunity to directly audit the quality and the quantity of communication and decision making with patients who have serious illness in hospital. I'll just highlight some of the findings from this work. It was called the ACCEPT study or the ACCEPT audit. Essentially what we found is that there is a substantial disconnect between what patients say they would want in terms of their medical care if they became critically ill, and when you compare that to what their prescribed care plan is. So I'll flesh that out a bit more. We directly asked patients in this survey if they were to become critically ill, what kind of care plan they might want, and those are summarized in the categories on the left here. So different gradations in terms of scope of medical treatment. So we've numbered those on this slide as preferences 1, 2, 3, and 4. And then across the top, you can see when we looked at the patient's chart and looked at what their actual documented goals or their medical orders were. So we looked in these same 4 categories. We were trying to get a sense of the extent of agreement between what patients say they want and what's prescribed in their chart. So the perfect world would be that all the numbers fall on the diagonal, and there's perfect agreement between prescribed orders and patient preference. You can see here not all the numbers are lining up in the diagonal, and so that in fact crude agreement was only 35%, which is quite striking. If we try to look at maybe the greatest magnitude of disagreement, so the things that were maybe not just tiny, more nuanced differences, but the biggest, most extreme differences, and called those a medical error. For example, here we looked at patients where they said they wanted essentially everything, but their prescribed or documented goals were something different. And then we also looked at the scenario where patients would have preferred a care plan that does not include CPR, so any of the options 2, 3, and 4, but their documented orders were in fact have CPR. And then of course there are situations where there's no documented order, but because the default option in hospitals is to quote, to do everything and perform CPR, those also were counted as instances of medical error, because if there's no order, then patients will receive CPR even if they don't want it in that scenario. So in terms of the medical error rate, it was 36%, and the vast majority of that medical error was due to potential under treatment, and in almost all cases was due to potential over treatment or patients being prescribed more aggressive care than what they would prefer. So a part of this audit, we asked patients to tell us what had been discussed with them with respect to their goals of care while they were in hospital. And this slide is showing that, in fact, patients reported that a lot of important issues were not discussed with them. And you have to remember that this was a very seriously ill population in hospital with a high risk of mortality in the next 6 months. And despite that high risk of dying, very few reported that their team had talked to them about their prognosis. Very few patients reported that they were asked about their values, so what's important to them as they consider healthcare decisions. They were not very frequently given an opportunity to express fears or concerns or asked about their preferences. So it's perhaps not surprising that given the low quality of conversations about goals of care in hospital with this high-risk population, it's not surprising that we're seeing the so-called medical error rates that I showed in the previous slide. So what to do about this problem, and why does this happen? this is a slide actually from Susan Block and her team that developed the serious illness care program that I'll be telling you about shortly. There's a lot of reasons, I think, that these conversations don't tend to happen, to summarize on this slide. Certainly, I think there are emotional barriers, both for patients as well as practitioners, that prevent each party from engaging in these conversations. Another big trap that we fall into, at least in the hospital setting, is this tendency to focus on procedures first when trying to sort out care plans with patients. Whereas it would be more meaningful to begin with the patient's values, which then can inform the right sort of care plan for that individual patient. I mean, the other thing on this slide, I think, is this issue about disclosing prognosis, that physicians are not very good about disclosing prognosis. We don't do it often. I think we're often afraid of having that conversation, or not sure how to have that conversation with patients. It prevents patients from having a full understanding of their disease. So onto the second section of my talk. So this is really about now the serious illness care program, which is something that was designed to address many of these barriers and address these problems. Atul Gawande, some of you may know, is a surgical oncologist. So he does operations on patients with cancer at the Mass General in Boston. And in his struggles in trying to understand his clinical practice and why it turned out that he or the system often provided sometimes quite aggressive and intensive interventions to patients who ended up dying anyways, he struggled with why this sort of happened in his practice and what could be done about it. And I think he was left wondering, why, was that the best thing for this patient, and why did we let that happen? And in his writing what became a New York Times bestseller called Being Mortal, interviewed a lot of experts, and one of the experts he spoke with was Dr. Susan Block, who's a very experienced palliative care physician in Boston. And Susan really had some very practical advice for Atul during this interview, saying, I think you should think about asking your patients these 4 or 5 questions. And none of these questions were about procedures. They were all about, how much patients understand about their illness, and asking about their values. And I'll go through it in more detail. But for Atul, this was an extremely transformative experience when he tried having this different kind of conversation with his patient. And so really they've spun that out into an entire program to try to support more and better and earlier and more person-centered conversations about goals of care with patients when they're facing serious life-limiting illness. And so that's what the Serious Illness Care Program is about. So Ariadne Labs is this group, I guess, or organization, nonprofit organization that's linked to Harvard Medical School, where Susan and Atul work in Boston. And really the Serious Illness Care Program, the centerpiece for that intervention is a tool for clinicians, for healthcare practitioners to give them a roadmap to have a different sort of conversation about goals of care, and to try to reorient conversations around patients' values and priorities before getting to conversations about procedures. And really the rationale supporting this guide and the whole program is the notion that there are, hundreds, thousands of patients who have life-limiting serious illnesses who would benefit from this kind of conversation, which is really grounded in palliative care best practices. The issue is that there's simply not enough palliative care physicians to have these conversations with every patient who could benefit. And so the guide and the larger serious illness care program is really trying to find a scalable solution to integrate palliative care best practices related to communication into clinical practice, so that it can be used by non-palliative care physicians or clinicians throughout the system. So in thinking about how they could achieve that aim, besides just creating a conversation guide and a tool for clinicians, they've thought carefully about other aspects that would be needed to really support this kind of large-scale change. So in addition to tools, you can see on this slide, another key component of the program is education. So simply handing out a tool to clinicians is clearly not enough to change practice on a large scale. So there's a need for education, and what they've come up with is a trade-off between really intensive training that might take several days, but that would clearly not be feasible for busy clinicians. And they've tried to scale it down to something that they think is feasible to spread widely, and that's a 2.5-hour clinician training workshop that involves more than 50% of that time as role play by clinicians with standardized patients to be able to practice using the guide and get direct observation and feedback. So the education is a critical element of the program, but even that is not, or their view, and I would agree with them, education is not sufficient to support large-scale implementation. Like they are big thinkers. They want to spread this globally, not just in Boston. And so what really is the last piece that's necessary to drive that kind of change? It's really changing processes within your system. And so they've really thought hard about first trying to piece together, like, what are the different steps that one might need to take to deliver this conversation to a patient, and then asking folks who want to take this into their own backyards to really think carefully about how those processes need to be changed in one's own local environment. And I'll talk more about that experience with the example from our implementation work at the Hamilton General Hospital. So they have been evaluating this program. So they've actually finished a randomized controlled trial and are analyzing data. So I would anticipate we'll see a publication in the upcoming year or two, depending on the vagaries of the peer review process. But early data in abstract form, just about process kind of measures, is very promising. And certainly in our interactions with the team at Ariadne Labs over the past couple of years, we really felt that there was a real potential for this intervention to have an impact in addressing some of the problems that I showed you in the beginning of my talk in terms of the deficits that we have related to communication and decision making in a hospital setting with patients who are seriously ill. And so to that end, we've been working in the past, I'd say it's been about a year and a half to adapt and implement the serious illness care program to our hospital medical ward setting. So I'm going to shift gears now into the next, 15 minutes or so, 15, 20 minutes of this talk to tell you about sort of as this slide says, some of the journey we've been through thus far trying to adapt and implement this program in the medical ward. One of the things that the Ariadne Labs team, I think, does really well is to provide support to either individuals or groups who would like to implement this program in their own setting. They provide a lot of training and webinars and documents to help support teams in implementing. And so one of the points that they make, and that's emphasized on this slide visually, is that the first phase of building a foundation is actually critically important to the whole implementation journey. And they've broken it down very practically into a number of steps, and we really found this very helpful in planning our implementation, which started last year in the summer, even though we only formally did our hard launch in March of this year, which is about 6 months ago. So, some of the things to think about are assessing readiness of your organization. Like, is there a major system change that, in our case, that the hospital is trying to push through during the time frame when you were planning to launch? Because if there's a huge change coming, really wouldn't make sense to try to also be implementing this program on your unit. Another really important piece in the preparation was the step of engaging senior leadership at our hospital, as well as colleagues within my own clinical group, through a series of one-on-one in-person conversations that I had. That's just a list of the sorts of people that I met with. But I'm confident in saying it's not an exaggeration to say that I probably had 30 to 40 one-on-one meetings with different people during the preparation phase before launching this program. Another thing to think about was, what drivers could we identify that would, and we were focusing initially on physicians in our medical ward setting. What drivers could we secure that might help facilitate, the physicians having these conversations? And so things like providing continuing medical education credits for their maintenance of certification or maintaining their license. So going through a process for accrediting our training workshops, trying to align our implementation with other activities or priorities that were important to our organization or the region, being clear about how physicians could be reimbursed on a time basis for having these meetings with patients or families, were things that we thought of. So on that earlier diagram I showed about implementation being a journey, then there's really a big step of, how do you adapt and customize the different steps in delivering this conversation to your own local workflow and environment. And so while we were having all these meetings with people in the preparation phase, we also pulled together our core team, implementation team, and started to think through, well, how would the process actually look on our unit? Who's going to identify high-risk patients? How will we identify them? How will clinicians be reminded, and so on? And so this slide here shows sort of a visual of the different steps involved in delivering a conversation. And I'll talk briefly about some of the adaptations that we made to roll this out on our medical wards. So in terms of how we would select an appropriate group of patients, the idea is to try to get people who are nearing the end of their lives, perhaps in their final 1 or 2 years of life. And we were able to take advantage of an already existing initiative at our hospital where they were trying to implement a more systematic assessment of elderly patients at the time of presentation to the emergency department, trying to look for high risk for functional decline or increased service use. And so we piggybacked on that screening initiative to help identify patients for our serious illness conversation guide. The clinician training workshop we didn't touch at all. The 2.5-hour format we felt was very suitable and well thought out. In terms of prompting clinicians, really what the model that we decided to adopt, and we can talk more about it during the question and answer period, was to have a unit champion who was formerly a nurse on one of our medical floors, really to be the boots on the ground that would help to drive a lot of these changes and processes. and her name is Shelley. I didn't notice on the participant list if Shelley's on the line, but Shelley is essentially doing a lot of the groundwork to help screen the right patients and act as the trigger or the prompt to personally remind clinicians that patients under their care are eligible for this conversation. And if the clinician sort of vets that that's an appropriate patient who would benefit, then Shelley goes through a process of in person rather than using a letter, which they do in the original design of the program in Boston. Shelley prepares patients and families in person for the conversation that's to come. So we've adapted some of the written materials that the Ariadne Lab folks have created in terms of patient preparation. And then Shelley really helps with a lot of the logistics about making sure that the right family members are present at the meeting and arranging for a private space for the meeting to occur and scheduling an appropriate time, a mutually convenient time for patient, family, and healthcare professionals from our team. So these are really scheduled as pre-booked family meetings on our medical ward. And then in terms of documentation, so our hospital really does not have a sophisticated electronic medical record at all. We're sort of a hybrid paper-based and computer-based. So the mechanism that we've come up with to try to document these conversations in our health record is for our clinicians to dictate a structured summary that follows the flow of the conversation guide in terms of major headings or major questions. And the advantage of having those as dictated summaries in our EMR are twofold. One is that any dictated summary gets automatically faxed to family physicians in our catchment area. So there's a way of trying to feed this information back to their circle of care outside of hospital. The second advantage is that it's easier to find dictated summaries on our medical records as compared to, say, written physician progress notes that get lost in a scanned electronic system. So those are some of the tweaks that we made. Like this program, some of you may be aware, was originally designed for an outpatient oncology clinic setting. So quite different in terms of the processes and dynamics. And so I think this just speaks to the need to tailor to your own local context. I'll spend a few minutes just giving you some numbers about what we've achieved so far in our implementation since March. And this is data from essentially March 1st of 2017 until the end of September 2017, so roughly 6 months. So I'll share a bit of data now so you get a sense of what we've been up to. And then I will share some perspectives about lessons learned and then open it up for questions. So the clinician training, we've delivered 4 accredited 2.5-hour clinician training workshops since the beginning of the year. And through this, I've been able to train 23 different clinicians, again, with a focus on our general internal medicine. That's what the GIM stands for. Attending physicians, but also ensuring that we reach some other key members of our interprofessional team. So for example, we have 3 nurse practitioners on our medical team. So they've been trained. We've also trained social workers and nurses, as well as some learners. We have another workshop that we're trying to deliver at the end of this month to catch the last few clinicians who work in our group. We have evaluation forms. We haven't analyzed them yet, but anecdotally, the training has been very well received by participants. So I spoke earlier about how we're screening eligible patients. So we've piggybacked on this assessment urgency algorithm initiative that's been happening at our hospital, or the AUA score for short, and really have made a decision with our implementation team to focus on the highest risk patients using that score. So it's a 6-point score, and we're focusing on those with a score of 5 or 6. Emergency room nurses are supposed to be doing this on every patient over the age of 65. How it's actually playing out is that for patients who are coming to medicine, to our program, about a third of them are having that AUA score done in the emerge, whereas the rest of them, Shelley, our unit champion, is having to do. So it's somewhat inefficient in my view that we're having our unit champion having to do the screening work, and then the Q&A period we could talk about different strategies for this. But that's how we've been doing our screening. I think the important thing to note at the bottom is that the other way that patients can enter into this program and have a conversation are if a member of our care team feels that there is, oh, sorry, that's not this slide, that's a different slide. The point I wanted to make is that the other way that patients can enter into the program is if a member of the care team feels a patient would benefit from such a conversation, they've been approaching Shelley for help to facilitate a family meeting to have this conversation. So summary of screening, the top left box saying 145 patients screened is actually an underestimate because we're still refining our data tracking procedures in our first couple of months. So we have to go back, but the actual number is probably closer to 200 or more that have been screened by our unit champion. In terms of those in the highest risk group, there were 125. And you can sort of work your way through the flow diagram. We've been able to actually deliver conversations to 44 different patients or their family members. So not too bad over a 6-month period, although the other side of that is that there's of course, hundreds of patients admitted to internal medicine in a 6-month period. But we're still quite pleased to see that clinicians are actually having conversations. One of the things that we've been trying to do, and actually I should have put this slide before the number of conversations, but is before we sit down and have the conversation in hospital, we're trying to reach out to our family physicians to ask them what conversations they may have had with their patient, or if they can tell us something about the patient or family that may be helpful for us in the hospital when we sit down for this discussion. Given that often in hospital we don't have a pre-existing relationship with patients. It's been a challenge connecting with primary care, and I can talk in more detail about that if people are interested during the Q&A. But we have been trying to put this process in place. So I already made this point earlier about about clinicians being able to trigger the conversations themselves, and as it's turned out, more than half of the conversations that we have delivered, in fact, were triggered by members of our care team, as opposed to Shelley screening an eligible patient and then connecting with a clinician to say, hey, you know, Mr. or Mrs. X is a high-risk patient who would benefit from the conversation. And it's a range of clinicians on our team who've been reaching out to us or to Shelley to have this conversation set up. So in terms of a bit more detail about the conversations themselves, as I said, 44 different patients or their families, and they've been delivered by 20 different clinicians who've received the training. So it's been spread out nicely so that a large number of people on our team have been involved in some of this work. We've been able to have almost all of these occur in a private room, which, given the content of the conversations, is, I think, helpful. And it's important to note that these conversations aren't quick. So there's a lot that gets discussed. There's a lot of questions that patients or families have. But I think the fact that our clinicians have been willing to have these discussions with patients speaks to the value to patient care that these discussions can have. So this slide is just showing who has been present at the meetings, and I think it's been good that we've been able to get family members present so that people can hear the same things at the same time. There are, of course, instances, for example, where the patient is too sick to be able to participate or doesn't have the cognitive capacity to participate in this kind of conversation. The documentation has been going fairly well, so all of the conversations have been documented somewhere in the record, and most of them have been documented as a dictated summary in our EMR called Meditech. So I'll just say a word about our plans for evaluation before I talk about some of our lessons learned. We are running this as a quality improvement initiative on our medical ward. So not as a formal clinical research study. The big implication of that is that we've been able to get a waiver of consent from our research ethics board, which has simplified a lot of our processes, I would say. And as part of the quality improvement framework, we have a number of measures or metrics that we are tracking to evaluate the impact of our work. So certainly we're going to look at process measures such as the number of clinicians who've been trained and the number of patients who had a conversation and the proportion of eligible patients who've had a conversation, things like that. In terms of actual impact, we're looking at outcomes or impact in 3 different ways. So one is to look at patient-family experience using surveys and possibly interviews. We also want to get a sense of the clinician's experience and the benefits it may be having for clinicians in terms of their own professional practice, as well as their perspectives on how it's impacting on patient care. Once again, we'll likely do this through a combination of surveys and interviews. For sure, we will do some qualitative interviews. And then finally, we are interested in knowing whether patients who have gone through this conversation, when compared to a similar group of patients who did not go through this conversation, whether there's any difference in downstream health resource use. So we've just started embarking on the evaluation activity in the last month or so, and we are starting with the collection of patient-reported or family-reported outcomes using a structured survey. It's been interesting to see in the early days, the first 6 months, what some of the impacts are. So this is all anecdotal. It's not part of that evaluation framework that's more formal that I showed you on the previous slide. But I think in the 6 months, we have been able to see already some evidence of culture change on our medicine wards like Hamilton General Hospital. The fact that clinicians are coming to Shelley to have conversations initiated, and the fact that the words serious illness conversation are now spontaneously arising amongst our healthcare team members, and that is coming up at our care planning rounds, I think is a sign that our program is taking hold, so to speak. And outside of our internal medicine program, there's been awareness from other clinical programs and other tables in the hospital, and I think that's been a positive thing and will help us move things forward. So when I was preparing for this talk, it gave me the chance to reflect for a little bit on some of the different lessons learned or observations during this journey. And so I'll kind of go through some of them now. First sort of category of, I'd say, lessons for me, not having really tried to do something on this scale before in terms of quality improvement or system change, was reflecting back how critically important these one-on-one conversations were. So as I said earlier, these were one-on-one conversations between me and senior leadership, including people like the CEO of our hospital, or chiefs of practice and so on, to get moral support and buy-in for the program, and the way that can potentially open doors if they're made aware at the beginning of what you're doing. When you face potential barriers down the road, having their backing can really help just reduce barriers that you need addressed to move forward. One-on-one conversations with my physician colleagues in our medicine group were also critically important. rather than sending a mass email out to my colleagues saying, please attend this clinician training session, I think it's really important. I think the sitting down with each colleague to tell them about how this program can improve care for their patients and improve their practice, give them a chance to express either concerns or ask questions about the program, and then personally inviting them to participate and to attend a clinician training workshop. I think that's been critical to get the buy-in and the participation of my colleagues in the training and in having conversations on the floor. I think it's been important to position this as us needing to own part of this problem. It's very, very easy to say in the hospital, oh, that this should have happened in the family doctor's office, and why do we have to bother with it? I think the messaging of saying that, we all need to take ownership and it's everyone's business to provide high quality end-of-life care is important in the messaging. And I already spoke about some of the issues around tailoring implementation to the local context so that it fits and it can synergize with other things that are happening locally. Just some of my observations in going through this experience in the last 6 months, and these are not in any particular order, but the challenge of connecting back to primary care has been really quite striking. I've made a number of efforts to try to reach out to the primary care community. We've involved an opinion leader in family medicine as a member of our implementation team. But I think, and I suspect this is the same in other jurisdictions, but maybe not to the degree that it is here. I think there's some historical basis. It's been challenging to engage family physicians more in our program and to share information back and forth. The second observation is, the raison d'etre of this guide is really to start conversations earlier in the illness trajectory to support more goal-consistent decisions and care as patients' illness progresses. And the original framing of the conversation guide, in fact, was to say to patients, we don't need to make any decisions today, but we just want to start a conversation. In our adaptation of this to the hospital setting, maybe naively when I started out, I thought it'd be great if we could try to catch patients earlier in their illness trajectory and start these really meaningful conversations that would hopefully alter their downstream sort of care trajectory. But what I've really found in our work in the last 6 months is that there's a very strong culture in the hospital and it's, I guess, a function of where the hospital is situated in the system. But there's a really strong culture of, we really need to make some decisions now as opposed to, we don't need to make decisions today. And a lot of it tends to get particularly focused or obsessed around code status. So even though we keep telling our team that this is not about code status, I feel like where our clinicians see a lot of the relevance of having these conversations is really to try to sort out decisions about, to what extent are we going to escalate care, and is resuscitation still on the table? Is ICU still on the table? And what is the scope of treatment going forward? And I feel like if there's a sense from the care team that those decisions need to be made but have not yet been made, that's often when Shelley will be triggered to have this conversation. So it's a different clinical environment, I would say, than the oncology clinic where this was originally designed. Another interesting observation for me has been just a surprise about going into it who I thought on our team might be champions for the program, and sort of some silent people in the middle who I wasn't sure whether they would or wouldn't champion this, who turned out to be really strong supporters. So I think it's important in those one-on-one conversations to go with an open mind, and you just never know who's going to step up, and not to write people off necessarily for whatever pre-existing views you might have. This is my final point, and then I'll look and see if you guys have hopefully been putting questions into the question box. I'll see what's there already. But I think just one of the last things is looking ahead. we've had the luxury of Shelley being funded through our research grant from CFN to do some of the important work related to this on the floor. And I worry about when we don't have Shelley's full-time support, how are we going to sustain the changes that we've been able to make so far? And I think over the coming months of the project, that's going to be increasingly an important question for us to ask and answer. So that's all I had to talk about. I would invite you to submit questions, and I'll try to get through as many as I can. We've got about 12 minutes left, so let me have a look and see what people are saying. So there's a question from Alexandra. Hi, Alexandra. About how many doctors have had the conversations of the 44 conversations that were done. I don't have the exact numbers in front of me. I would say, we've trained about 14 or maybe a bit more of our attending physicians from our group. Our total group is 20, sort of regular, 20 physicians who regularly rotate through our ward. And I'd say 10 to 12 different physicians have had maybe 3/4 of the conversations of the 44. And then the remainder have been led by our nurse practitioners. It might be even more that have been led by our nurse practitioners. And in fact, more recently, what's been interesting is that one of our social workers has really stepped up to sort of co-lead these conversations with physicians. Sometimes what's happened is there'll be a medical resident who hasn't had this training, and our social worker is able to lead large parts of the conversation with the resident present to be able to share information about illness understanding and prognosis. So I hope that answers that question. So Jillian, hi Jillian. Jillian has a question about, I think it's a question, so I'm still trying to figure out how to use this commenting function. Oh, so no, Jillian just making a comment about interesting to see how the implementation is differed in an inpatient hospital setting compared to the outpatient oncology setting. So Neha, hi Neha, who works in a primary care group in Hamilton with as a research staff with Michelle Howard on the primary care arm of our iCAN-ACP study. Neha is asking, longer term, could family members be more empowered to initiate conversations to increase sustainability? I think that's a really important point. Whereas we've been really pushing clinicians and the system to try to reorient itself to trigger more of these conversations, I think there's something to be said for a different, maybe complementary strategy of trying to activate patients or families in different ways. For example, if they had more exposure to advanced care planning before they arrived in hospital, that might prime them and empower them to, ask their physicians or their care providers in hospital to talk about their wishes and to talk about their goals of care. So I think that's a great point. And one of the things we're thinking of doing as this implementation rolls forward in iCAN-ACP in the hospital is to see how we might be able to embed other patient or family-facing decision support tools that might have that sort of empowerment function to see if we can further sort of maximize our gains in the work that we're doing. Just scanning to see if there are other questions coming in. Well, so far, no further questions. So we've got 8 minutes, and we can either end early, or if people have other things to talk about, then I would welcome you to type away and put in a question or two. One of the things that I was talking about earlier and didn't want to get into too much detail about during the presentation was our strategy for screening eligible patients. So, in the original formulation of the program in Boston, they're using the surprise question as the trigger to identify high-risk patients. So asking clinicians really to be involved in the screening process. So the surprise question is, would you be surprised if this patient died in the next year? In the hospital setting, we thought about using that as a potential approach. Although one of my physician colleagues on our implementation team had an interesting response saying, well, the physicians might just say, yes, I'd be surprised if this patient died because it would allow them to avoid having to do more work. So the approach that we've taken is to use this existing screening mechanism, this AUA score that's happening in our emergency room. But because only about a third of our patients are having the score done in the emerge, Shelley is having to spend a fair bit of time doing the screening, which is, what I would view as maybe not the best use of Shelley's skill set, because she's a very good communicator, and there's some things that there's really no one else who can do some of her role, like preparing patients and setting up meetings and so on right now. And so one of the options that we've been looking at is whether we can use some type of automated tool, like a risk prediction score, to automatically on the back end look at the patient's risk of mortality using data that's available in real time in the hospital EMR, to then flag patients who have a high risk of mortality. We'd have to set a threshold based on a validated score. And I think there's some opportunity to do that. There's a lot of people who've been working on these kinds of tools, and EMRs are pretty sophisticated these days. There's another question coming in, and this might be the last one that we'll be able to take, which is, this is from Seema. So, hi Seema. Could you provide more information on how the patients were prepared for the conversation? Had they met, sorry, I just moved my question box. Had they met Shelley prior to being identified as patients that could use this conversation? So the short answer is no, they wouldn't have met Shelley. So the way it works is Shelley would identify the patient using the screening mechanism with the AUA score, or the clinical team comes to Shelley saying, Shelley, Mrs. Jones, bed 9 or room 9, we think really we could use a conversation. And so Shelley has developed a script that's an adaptation of the letter that the Ariadne team has been using in their oncology clinic work. And Shelley essentially introduces herself to the patient family, tells them what we're doing with this quality improvement initiative to have better conversations, and leaves behind, in addition to some verbal preparation, leaves behind a piece of paper that will allow patients or families to write down some questions that they may have, or some answers to prompts that might help the clinician during the conversation sort of tailor some of the content. So to answer the question from Seema, so Shelley's meeting these patients for the first time. So we clearly carefully sort of recruited the person to fulfill this unit champion role. We wanted to make sure it was someone who was passionate about this area, who has good communication skills, and I think Shelley has really flourished or blossomed in this role. And I think the patient family preparation piece has been critically important, to give them that chance to reflect ahead of time, to make the conversation as meaningful as we can in a busy hospital environment. So hopefully that answers your question, Seema. There's a follow-up question from Alexander saying, how often is that paper written on, or does it function as a useful token reminder to leave behind? So I don't know for sure the data on all 44 conversations in the first 6 months, but I can tell you of the 8 or so conversations that I've personally led as part of this program. I would say that the paper is written on almost every single one of the times. So I actually can't remember a time when something wasn't written on the paper. I mean, sometimes it's not super informative, but sometimes it's actually quite provides you with a lot of insights about where the patient or family might be in their headspace. So, oh, Shelley is sending a comment to say that those preparation sheets are written on 95% of the time by patients or families. So I'm looking at the clock and it says it's 12:58 p.m. So I think I'll wrap things up here and just thank everyone for their participation in this inaugural sort of first iCAN-ACP team webinar. We're planning to have our next webinar early in the new year, and I'm pretty sure that it's the long-term care arm of our iCAN-ACP project that will be responsible for finding a speaker and presenting some content. So we look forward to that, and Marilyn will send out details of the time and date and the title of the talk in the coming weeks. So thanks again, everyone, for joining, and have a wonderful rest of your day. Bye-bye.